See if I'm recording. Yes, I am. Good morning. Welcome to MED220 9DAX. And again, like what we've been doing for, we had a little bit of break because of the midterm. But the second half is the clinical portion of this course, hence the term professional procedures. So the first half was, of course, how to be professional to get the job in the first place, and the second part should be a reviewer of these basic skill sets like EKG, phlebotomy, urinalysis, and during week 8, week 9, and week 10, and 10, of course, is the final written examination. We'll be having little laboratory things and laboratory checkoffs to make sure that those of you who are going into externship, that you guys know what you're doing. Now, like I stated, I wish the pandemic didn't happen because the way I designed this course in the past, starting from week 4, we do lab stuff all day, every day, no lectures, but we got to pivot and we have to do what we need to do. So today's topic is electrocardiogram and the related items to electrocardiogram. And you'll notice there's no homework or discussions. I'll be adding homework. But you know what? I think you guys did enough discussions, and you probably have enough discussions for your other classes. But the rest will just be homework that's going to prepare you for the final written examination in week 10. And I will also post today the exact dates and times of both the Friday and Saturday labs. So if you can't make it to the Friday lab, try to get in on the Saturday lab. And if you can't get to either one, give me a call, because I'm on campus starting in 2 weeks, almost every day, so that we can do one-on-ones. We get you checked off, because the didactic portion, you had this before. This is relatively easy. Well, in theory, you guys had this. So did both of you had these courses already? EKG, phlebotomy, and MED140, which is your, excuse me, basic clinical procedures. Did you guys have them both? Yes?
I did.
You guys
I've only had basic clinical procedures.
Okay, so the lab will be super important for you if you've never had these stuff before, because it's the condensed version. But the neat thing is, for the EKG, I've broken it down to everything that you need to know for your future registry examination and to do an EKG. Phlebotomy, I took all that others, took all the anatomy and physiology stuff out, and we went just to the crux of the matter, which is color top tubes, order of draw, and how to look and fill out requisition forms. And last but not least, this urinalysis. You come to lab, I could teach you this in 20 minutes instead of like this, it's more of like a hands-on thing for week 8 and week 9. And if you want to still work on skill sets in week 10, that's okay by me. But we have, I always have week 8, week 9 reserved for lab. And excuse me. We try not to keep you on campus for safety reasons, for health reasons. Okay. And you hear I have a cough. Already got checked out. It's not the COVID. I just got a normal cold. Remember that? Normal colds, right? So, but if I am symptomatic on week 8, I'll inform you guys, because part of our protocol, whether I have COVID or not, if I'm coughing or have a fever or anything like that, I can't be on campus. So I'll inform you about that, and then we'll have, like, I guess, something alternative. But my invitation to you guys to come on any one of my future laboratories, because you guys paid a decent coin to have a lab. So if you want to come do a one-on-one, and for maybe something that you're not so good at, I had a couple of graduates come in the other day, because they're doing IVs. They're already nurses. They made it to nursing, and they totally forgot how to do phlebotomy because it was more than a year ago. So they came in 45 minutes, not even an hour. The rest of the time we were there talking about their training and things like that. But it's nice to come back to the lab and have a refresher. And for those of you going into your internship, this is vital to shake the rust off of your skill sets. Your analysis is pretty straightforward, but phlebotomy can be tricky, and EKG is pretty straightforward. So let's jump right in and look at first the anatomical things you need to know about EKG. So click here. I have some notes. And this first part here is, did I put the wrong notes? I just put the outline. I should put the notes. All right, let me do it from scratch. And then later I'll switch the notes to more cardiac. But the things you need to know regarding cardiac is, the first thing you need to know is this. Just the simple anatomy of it. So you look up the external structures of the heart, and you've seen this in anatomy and physiology and other classes. You've seen this picture a million times. Let me copy this image and let's put it on a Microsoft Word document. Now, the first thing you need to know about the heart is, regarding its anatomy and physiology, is, can you tell the difference between the front and back? So you guys had anatomy and physiology before. You tell me, what's the difference between the front and the back? You could either put it on chat or unmute yourself. How do you know this is the front? How do you know this is the back without me telling you? Don't jump all in at once. Miss Cynthia, how do you know which one's the front, which is the back? Just by, let's see, you forgot. But what makes this different than this?
According to the post, oh my God.
Now, I'm sorry to call you guys out, but this is the problem with education in general, right? And retention. You guys probably aced your anatomy, physiology, your medical terminology. But what happens the thing about the brain is, if you don't use it, you lose it, right? So the superior vena cava, okay, it goes, that's how I can tell the front and the back. Well, the back has an SVC, the front has an SVC. That ain't it, right? So how's this? What do you see? Do you see this? Those are your atria. And remember your orientation. If you're looking at somebody from the front, this is their left and this is their right. So do you see the right atrium and the left atrium? They're prominent. If you look at the back, what's prominent in the back? The great vessels. So that's the first hint. Your atria are in the front. The next hint is, if you recall your anatomy and physiology, did any of you guys had an A&P with me? Nobody? No, you guys didn't have anatomy and physiology with me?
Nope.
If you remember, lab, right? You remember when you looked at the front, this groove here that had your great cardiac vein and your anterior interventricular artery, also known as your left anterior descending, it kind of went like diagonal, it goes running diagonally towards your heart. Like if you held your heart up straight and the apex was the bottom and your great vessels were the top, this thing ran diagonally. Well, if you look at the back, the posterior interventricular sulcus or groove goes straight to the apex. This one goes diagonally. So that's how you can tell the front and the back, because in anatomy, right? You could sit and try to memorize all these, but what happens if you don't understand what you're looking at? You may get it for the exam, but then when you have to go look at maybe what do you call that? A lab report or some or maybe because we don't know where we might end up. You could end up in a cardiology office, or if you're you're looking at some cardiologic test that your patient had. The front is because the atria are here and the anterior interventricular sulcus, and use your medical terminology powers, interventricular, meaning in between the ventricles. So this has to be the left ventricle. This has to be the right ventricle. This has to be the right atrium. This has to be the left atrium. And remember, blue usually means vein. Red usually means artery, unless there's a pulmonary circulation. And then it's backwards. So what could I do for the exam? Could I easily take this, erase all this? Or you know what? I'm not even going to erase it. I could easily do this. External structures of the heart quiz. Boop. Label A, B, C, D, E, F, G. Nah, I'll even just get this one. Right? Or anyone. And then you should be able to do what? So now that we had that diagram, let's say I gave you this diagram out of the blue. And how do I know this is the front? Here's the atria, they're sticking out, and the anterior interventricular sulcus is going like kind of like down and not towards the apex. The apex is like here, so it's kind of, use your imagination a little bit like this. So if I asked you what this was, what would this be? Anyone can call out. What would this be?
Atrium.
Atrium, which one, right or left?
Right.
Right, good. This one?
Left atrium.
And this? This big room. And it's on what side? The right side. So that's got to be the right ventricle. And then on the other side of this interventricular sulcus, left ventricle. I could ask you, hey, what's this? Oh, that's the great cardiac vein. Hey, what's this? The left anterior descending, because it's on the left side, it's in the front, and it's going down. Now, why am I pointing out the left anterior descending so prominently? Because your LAD is the most common artery, coronary artery, that gets blocked in a myocardial infarction. And anyone can tell me what a MI is, a myocardial infarction. If you saw that on a report, what would a layperson call a myocardial infarction?
Heart attack.
That's it. And that's all it is. A heart attack is just the blockage of these coronary vessels and corona surrounding. Now, let's look at what does the backside look like? Well, the backside, we now know what the front is. Now, the backside, this is huge vein. It's pretty big. It's bigger than these little ones. And that's your coronary sinus. And if you recall the lab, that was the squishy part in the back. Another thing you're going to notice, hey, look at, there's a whole bunch of great vessels. And you use your imagination a little bit. Do you see there's a pair here and a pair here? And it's red. That has to be your pulmonary veins. And if you're looking at the posterior view, do you now notice left is left and right is right now? Because now you're looking at the backside of your patient. So this has to be the left ventricle, posterior portion. This has to be the right ventricle. This little tiny part here has got to be sticking out of the left atrium, and that's where your pulmonary veins empty into your left atrium. And there's one set here that goes to your right lung, another set here that goes to your left lung. You have your pulmonary artery, which is deoxygenated, meaning to say is the red blood cell carries carbon dioxide. And you have one here, and then you have one here. So can everyone see that there's two sets? And your aortic arch, which is the biggest artery you got. Superior vena cava, inferior vena cava, right? And the posterior interventricular sulcus, you see it? It's going straight down and it's heading right for your apex. And that carries the middle cardiac vein. and middle cardiac artery as well here. And those could be stuck. Any of these can be stuck by an atherosclerotic plaque, right, which is a hardened fat. And then if your heart gets no oxygen, what will happen to the electricity? What do you guys think? Because now the next thing we're going to be talking about, well, we'll talk about the internal structures, but because that's what we're talking about today, EKG. Because when you think about it, let's draw a little diagram for you here. When you think about it, all the heart is, the brain gets connected into a nerve, and in this case, it's cranial nerve 10, and that's the Roman numeral 10, that X, also known as your vagus nerve, and that connects into your heart. And then the heart, of course, has this conduction system of nerves we're going to go over in a bit. So if something's wrong with my heart, don't you think the electricity is going to get messed up as well? And that's how we can detect heart problems. So if anything happens to his heart, it's all this heart muscle, or if blood flow isn't efficient here, we can detect the minor changes in electricity in our heart, hence the term electrocardiogram. Gram, measurement of electricity, and cardio, of course, the heart. Now, just in the last 10 minutes, we talked medical terminology, we talked anatomy, we talked physiology, which also goes to show that just because you had a class before, you're going to see it again. So let's wrap this up with the internal structures of the heart. Okay, internal. Because if you need to know the external, I need to know the internal. And here's a lovely picture. Oh, they wiped out all the nice tidbits, but we found a good one right here, and I'm going to put it here. And this Microsoft Word document, I'm going to keep on filling it up with pictures and things. And you could use that to study off of, because hint, hint, what is going to be on the final? Could I put a picture here, A, B, C, D, E, F, G? Sure. So we look at this. Now that you guys know orientation and I'm facing my patient, so what's this side right here? Is it right or left? Well, this gives it away. But we know that what? That's the left side of my patient. We know that this is the right side of my patient. We already know if this is the right side of my patient, this small room on the top has to be the right atrium. This big room on the bottom has to be the right ventricle. This little room on the top has to be the left atrium. And this big room on the bottom has to be the left ventricle. We're all in agreement there. But here, how can you tell the difference between an atrium and ventricle? Anybody? What's the difference? There's two main differences. And even if you don't remember it from your anatomy and physiology, just look at it, like matter-of-factly and logically. What does this look like? How does this differ than this? How does this differ from this? Miss Roxana, how is it? Just look at it. Just tell me commonsensically. How is this different than this?
I think the right atriums have the arteritic similar valves bigger.
Well, because they both have valves, but how's this? Hint, hint. What can you tell me about the wall? This wall bigger versus this wall. It's bigger where?
From the top.
Up here?
I guess, yes.
Look how thick this is.
Yes.
Look how thin this is. Now, do you guys remember your systolic and diastolic? The atria, is that high pressure or low pressure? Now, do you guys see how it's now difficult? Right? The easiest things, start becoming very difficult, because what were you guys doing before? You weren't doing anything wrong. You were memorizing, because that's what Grade school, high school, and other colleges have taught you to do. Memorize, memorize, memorize. But the problem is when there's 1,000,002 things to memorize, how do you keep it all straight in your head? It's really hard, right? I'm not doing it to show you that, oh, look how stupid you are. No, because I memorized stuff all the way until medical school until I realized you got to make sense of it yourself. So right off the bat, you know that the atria, you recall from your lectures, it's low pressure. And if something that's low pressure, does it need a thick wall? Nah. And also, you know, the atria is up top, right? And there's no valves coming into the atria either, right? You hear this is the entrance to the superior vena cava. This is the entrance to the inferior vena cava. So this is low pressure, also known as your diastole. Remember, you have a blood pressure 120/80. The 80 or the lower number is your diastolic. But let's look at the ventricles. Do you see how thick the walls are compared to the thin-walled atria? And can you also see the trabeculae carnae? It's all like rough, and there's a lot of branches. And carne, those of you who speak Spanish, you know it means what? Meat. There's more meat down here. And trabeculae or trabeculations is like means branching. So you could see here the ventricles are under higher pressure. They have a thicker wall. They have a rougher wall to deal with the pressures. But the atria, not. So identify trabeculae carnae. You can identify the wall, right? Thicker, right? You can identify the pericardium here. This little yellow line here, right? So that's your atria, that's your ventricles. And if you know these are your atria, these are your ventricles, you know the holes that come in, you also know the valves. These are your AV valves, your atrioventricular valves, because it's between your atria and your ventricles. So the one on the right side, that's got to be your tricuspid. And if I show you this picture, here's the hint. 1, 2, 3 papillary muscles connected to your chordae tendineae. And remember 1, 2, 3, like 3 wheels on a bicycle? That's your tricuspid. But you see here, there's 1, 2. So on the left side of your heart, that's your bicuspid, which is your AV valve in between your left atrium and your left ventricle. So to recap, right side, AV valve, tricuspid. Left side, bicuspid. Okay? And you have your papillary muscles, and papilla, it looks like a little fingers. And then the chordae tendineae, it's a cord. And what's a tendon? A tendon connects muscles to some connective tissue, which is this valve. So do you see how, like, I can tell like a story? And that's my way. But, you know, when you go study, make it your way. Another way, when I was training my daughter, she's a nurse now, when I was teaching her anatomy, she learned it like, oh, these are the houses. This is the house. These are rooms, upstairs rooms, downstairs rooms. And these are the doorways leading out. And here's a doorway right here, leading out from the left ventricle through here, out into your aorta. And that is your aortic semilunar valve. And you can use your imagination a little bit. If you look at this pulmonary semilunar valve, it looks like a little crescent moon. And that's how you kind of remember it. So if you have your pulmonary circulation, which is deoxygenated, right, you have your pulmonary semilunar valve. Okay. So to recap, this is your right, this is your left. Mitral valve, also known as bicuspid, tricuspid valve, pulmonary semilunar valve, aortic semilunar valve. This is your pulmonary artery, right? And this is your aorta. The pulmonary artery is coming from here, right ventricle, and your aorta, you got to use your imagination a little bit, is coming underneath here and up and out. And what could you do? Every day, you take 5 minutes, you find a quiz, something like this, and then just test yourself and use logic. Try to use logic and try to use your own understanding of what you're seeing as a guide. Now, Now that we're in the internal structures, let's now talk about the main star of what we want to talk about, which is the conduction system of a heart. And there's this lovely video right here, which I use on at least 4.
Shopping with Google helps you find
at least 4 different classes. And it's the same video. It's the same animation. So wait until this ad is done. Okay.
The cardiac conduction system consists of the following components. The sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The Atrioventricular Node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles.
Okay. So you have your vagus nerve and also some other sympathetic nerves that are coming into your heart from your brain. And the first station is here, this bundle of nerves called your SA node or your sinoatrial node. That's called the pacemaker of your heart. It runs about 100 beats per minute. Now, your heart shouldn't be running 100 beats per minute, right? Normal is 60 to 100. 100 is on the higher end of normal heart rate. But that's why you have this AV node. The AV node, they call it the gateway, but I like calling it the brakes. It slows it down and it gives time. See this blood here? You have blue for deoxygenated. That means the red blood cells usually carrying carbon dioxide. And then you have the red here, which is the left side, right, from the left atrium. And that is oxygenated blood, meaning to say is the red blood cell is carrying a lot of oxygen. So you see that it takes time for the blood to come in and has to go down. So there has to be a delay between here and here. And that's why the AV node is called, I call it the brakes. Textbooks call it the gateway. And also, since this yellow stuff here, that's the electrical impulse, also known as your action potential, right? And that's the electricity that your EKG is detecting. So if I have an SA node, that means I have some sort of atrial problem. If I have a AV node problem, that means I might have a junction problem between your atria and your ventricles. And then if I got a problem here, it's probably septal wall problem. Problem here, septal wall, interventricular. Problems down here and here, that means I have a ventricular problem. So when you're looking at your EKG and the waves represent different parts and different timings of this yellow or this action potential. So knowing that, let's replay a little bit and then continue.
Contract. The Atrioventricular Node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle.
Okay. So you're going to see an animation, and everything starts here in the atria. So the P, now, if you're looking at EKG wave, if you're reading it from left to right, that's timing. So who comes first? P wave, then QRS, and then T wave. It has to go in that order from left to right. Now, if you're looking at the waves from top to bottom, or sometimes they call them deflections, right? If you're looking at this P wave deflection, it shows the amount of electricity. So, of course, this P wave here coincides with atrial depolarization. Now, what does depolarization mean? Depolarization means doing work. Have any of you guys ever messed around with a 9-volt battery? You know, the battery that has like the plus and minus at the top? If you touch your tongue on just the plus side, do you get a shock? No. If you touch your tongue on just the negative side, do you get a shock? No. It's the same thing when you mess around with, jumper cables with your car. But what happens if I mess with the jumper cables or I mess with that 9-volt battery and I put my tongue on both the left and the right little nubs on the top of that battery, or the plus and minus? If I put plus and minus together, what will I get? I will get a shock, right? I will get an action potential. Hence the term depolarization. D means no or not. Polar means opposite. So it means bringing the plus and minus together. And that's what your heart cells are doing. They're bringing the plus and minuses together, these nerves, and it creates electricity. And then the electricity signals the heart to contract or pump. So the P wave is atrial depolarization. The QRS, and that's a complex because it's made out of 3 waves, your Q wave here, your R wave, this big thing here, and the S wave. And that's ventricular depolarization. That is when your ventricles are now doing work. And you know the ventricles are much, much bigger. They're heavier, right? They're much greater pressure. So they're going to require a much greater amount of signal. So the deflection for your QRS complex is much higher. So on an exam, I could ask, what does the P wave mean? Well, you'll tell me atrial depolarization. Hey, what does the QRS mean? Well, that's the ventricular depolarization. Now, when does the heart get to reset? And that's this T wave here. So in between your S and your T, all of this resets for the next P wave QRS complex. And this is where we see heart attacks. We see it in changes between the ST segment here. This will get longer and shorter, and you'll see a T wave inversion. This T wave will be upside down. And that's how you know your patient has a heart attack. It's a very common thing to see. So let's watch the rest of the video and see the timing of it all. And these are segments or intervals, and they talk about timing. So again, when you're looking from left to right, you're thinking in milliseconds. This has to come first, then this, and then this. And there's a delay or a space here, a delay, and a space here. And if you're looking at it deflection-wise up and down, you're thinking what? Millivolts. So let's watch this and see how it all comes together.
When the atria are full of blood, the SA node fires. Electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation.
Now, repolarization is different from depolarization. So repolarization, that means all the ions, the pluses and minuses, go back to their sides. So they separate. And if they separate, there's no more electrical conduction, and it resets and recharges for the heart to pump again. Okay? So I could ask you, what's P wave? And you'll tell me, oh, that's atrial depolarization. I'm doing work. What's QRS complex? Oh, that's ventricular depolarization. I'm doing work. But what's the T wave? The T wave is ventricular repolarization to reset, recharge the ventricles. Now, you may ask, well, Dr. Garais, where's the atrial repolarization? Well, it's somewhere in here, but it gets obscured by this huge QRS wave. So know your P wave, QRS, and what T wave means. Know the difference between depolarization or doing work, and remember my battery story, and repolarization, think recharge, reset, right? The pluses and minus ions go back to their corners, and you know when both fighters go back to the corner, no more fight, no more spark, nothing. And then you see this.
Ventricular diastole. The cycle repeats itself with every heartbeat.
See? And that's what, because that's what you should see normally. So that normal, okay, what happened to that normal will show you this. How can I make this? Can I take this and I want to make it the other. Oh, here's you. You know what? Let's find a picture that's right side up. So how do you know something's normal? Okay. This is your typical EKG, and these are the leads. And we're going to go over the leads and what they mean in a moment. So here are your chest leads. I mean, not your chest leads, your limb leads. Limb lead 1, 2, and 3. You'll also see your augmented leads, AVR, AVL, AVF. And here are your chest leads, V1, 2, 3, 4, 5, and 6. And then you have here, oh, it's missing your lead 2. Let's find one that isn't missing lead 2. Here you go. Here's a better one. Okay, so again, we have 1, 2, 3, right? These are your limb leads. Here are your other limb leads, but these are the augmented ones, AVR, AVL, AVF. And here's your long lead 2. We call it long because it's a long strip. And here are your precordial leads, also known as your chest leads, V1, 2, 3, 4, 5, and 6. So how do you know what's normal? Those of you who had EKG before, tell me what these things are. What is this square thing? And is it important? And what does it mean? Who had EKG before?
I have
Anybody?
not.
Yeah, so Miss Roxana, Miss Tamiko, you had it before?
No, not me.
No, I haven't.
No one had EKG before? Okay.
No.
So let me break it down because this is the first time you see it. So these are your leads, or the stickers, the little electrodes. Don't call them stickers or stickies. They're electrodes. And they're just different views and different cameras on your chest. So if you see this bar here, this little tower, these are calibration towers. Now, do you notice how the baseline is all straight? That's the way you want it to be. If it starts going up and down doing craziness, you gotta diagnose it, and it's something wrong with the little alligator clips. And again, like I said, this is a lab class, and it's if you missed the lab, the stuff that we're going to be talking about here won't be solidified. So these are your calibration towers. Do you see how they're all the same? That means that this EKG machine is good. Do you see the baseline? It's pretty much straight. That means the what do you call that? The little alligator clips that click onto the electrodes, or the sticky parts, right? Let me show you a picture. See this thing? Right? Oh, they call banana tabs. I've heard that before. But I'm old school. We call them alligator clips because back in the day, they look like this. They look like little alligator clips, little roaches, And by the way, be careful. These things only come in packs of 10. It is the industry's way of maximizing cost. You break one, you got to buy the whole pack. It's a pain. So if these get dirty and they get a lot of the electrodes, see these electrode tabs, they have a lot of adhesive on it. If these get dirty, this starts going woo, and goes all over the place. Okay. And that's called a wandering baseline. And that's not good. And your physician can't read that. So if we look at all of these as separate cameras, these are your limb ones, 1, 2, and 3. That's Roman numeral 1, 2, and 3. AVR, AVL, AVF. A stands for augmented or unipolar. And then you have your chest leads, the one we put on your chest. That's V1, and it starts on the right side of your sternum, and then it moves all the way across to the left side of your body. So that's V1, V2, V3, V4, V5, V6. Now, how do you know this is normal? First of all, if you look at it, can everyone see like a nice P wave here, a QRS, and a T wave? Does everyone see that? On this one? Everyone see it on this long lead too? It's there, right? And can everyone see that it's pretty consistent? It's not like craziness, right? So it looks kind of uniform. So right off the bat, that's telling me this might be NSR or normal sinus rhythm. Another thing that's telling me, right, is if I look at lead 1 and lead 2, and this one's a little off, but lead 3 sometimes is upside down. You see lead 1 and lead 2, everything's upright. That makes sense. AVL too. It looks upright because the cameras in these 3 sites are upright. Now, you look at the long lead 2. Do you see this QRS, QRS, QRS? Do you see the R, which is the pointy parts up here? Can you guys see how they're pretty much even between each other? That's good. That means that the heart is beating normally. Because remember, when we read from left to right, it's timing. And last but not least, if you look at the V1, 2, 3, 4, and 5, 6, do you see how the QRS is kind of like upside downish? And then it writes itself up. Then it gets bigger, and then it gets bigger, it gets bigger, and then it gets a little smaller. And that's from your V1, 2, 3, 4, 5, and 6, where it gets bigger, 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 and then smaller. Right? That's called your progression of your precordial leads. That means because your heart's on the left side, and it should be the loudest electronically where? On the left side. But then the V6, you'll see the placement of that. That's like all the way on the side of your body away from your heart. So this one's going to get a little bit smaller. So this one's like 2.5 big boxes tall. This one's definitely 3 big boxes tall. So it's getting just a little bit smaller. So that's how you can tell what's normal. So on an exam, I could ask you, hey, is this normal? And you'll tell me, yep, that's a calibration tower. They have to look equal. Hey, is the interval between R to R waves on the long lead 2 normal? Yep. Hey, is there a progression of my QRS complex? Is it getting bigger, 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 and then a little bit smaller on the V6? Yep. So all of that put together, you have a normal sinus rhythm, or NSR. And this is the thing we'd like to see. Anything that deviates from this is what? Abnormal, right? And when you have your EKG class, you'll go over all the abnormals, well, all the basic abnormals. So here's an example of some abnormals. Does this look normal to you? Right? There's what happened to the P wave? It's non-existent, right? And there's too many of them. So this sawtooth pattern, this is supraventricular tachycardia. This is bad news, right? How about this one? And this is normal VTach, right? There's a P, QRS, T, P, QRS, T, but there's way too many of them. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Since there's 14 QRS complexes within a 6-second strip, that's about 140 beats per minute. So this is ventricular tachycardia, also known as VTach. No, I'm sorry. This is just regular tachycardia. This is not VTach. Now, do you see these 2 ones? There's not too many of them. That's really slow. So that's got to be bradycardia. This is barely 30 beats per minute. Actually, this is complete heart block. But you could look at it. There's a whole bunch of missing things. And oh my goodness, look at this. You have an upside down, goes upside down wave. That's not good, right? So you could see, right, even though we didn't show you any abnormals, that this totally does not look like this. This looks normal. I have a P wave, QRS, I have a T, they're evenly spaced. The baseline is straight. You're good to go. So that's what's normal. Now, how do you know where to put all the leads? And if you open up EKG lead placement on my notes there, these are your precordial or chest leads. And you could see here how, remember, it would get louder and louder and louder and louder. And V5, it'll be its loudest because your V5 is at the location near where your apex of your heart is. And that's what they call your PMI, or point of maximal impulse. Everyone right now, take your hand and put your hand on your chest. Okay? Now, there's going to be a point where you can feel where your heartbeat is the strongest. And odds are it'll be around this area right here. So where are they? It goes, how do you place it? Because the first 2 are on your 4th intercostal space. Everyone now at home, feel your collarbone on your right side. Does everyone feel it? You got it? You can even look at my webcam. I believe my webcam's still on. Can everyone see my my webcam? Where's my cam? Oh, wait, here's my cam. If you could see my webcam, I'm on my right side. Does everyone feel like there's your collarbone right here, right? Everyone got it? Right underneath, you feel there's a depression. Okay, so here's your sternum. And here's your collarbone right here. Let me get another light on. Everyone feel it right here? Like there's like a depression. Hello? You can unmute. Everyone feel it?
Yes.
Okay, that's your first intercostal space. Then you feel a bone, then another space, second intercostal space. Then you feel a bone, another space, third intercostal space. So that's what those ICSs are. Or let me go back to my notes. Where are my notes? That's not it. Here it is. So that's what I'm palpating or feeling for. Okay. Now, I always tell this story. It was a couple of years ago. I had pneumonia, and when when the student, not the student, when the technician was doing an EKG, she was just putting stickers on me like blah 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 blah, and it was close, because you know what she told me, and this is the tech in a hospital. I go, hey, because I always go to hospital, I always pretend to be a layperson, like I don't know nothing, so I could see how they are and what kind of craziness they could say to me. Oh, and every time I go there, tech or a nurse or a doctor says some craziness to me, right? Even a doctor. So that's why know your anatomy and physiology, know your basics, so you can able to answer your patient accurately. And I asked her, how do you know where to put these little stickers? And she goes, well, you just follow the picture on the machine. And then my wife looked at me and said, don't say it. Don't say it. There's specific areas that we put it on. And especially now, here's the thing about modern technology. You could put it in wackadoo places, but a modern machine that was built maybe in the last 5 years, they compensate for differences in anatomy and differences between electrode placement. But again, this is college, and some of you guys have endeavors for nursing. So we have to be exact, okay? And when I was trained, I wasn't trained like, oh, follow the pictures. That's stupid. There's a reason why we're telling you where exactly is. So V1 is fourth intercostal space. So I'm going to count space, bone, space, second space, third space, fourth space. So I'm going to count down 4 spaces for my V1. Right sternal border, because this is the right side of my patient. So that's my V1. The V2 is directly across from it. So it's fourth intercostal space, left sternal border. Now, the tricky one is V3. So you're going to skip V3 and jump right to V4. V4 is fifth intercostal space, mid-clavicular line. So if I have my collarbone here, right? Those of you watching either on my video or this diagram here on the shared screen, you draw an imaginary line. Do not draw a real line. 10 years ago, I had a medical student who did this to my patient. Because I did that in class. I drew a line right here on me, and she thought it would be okay to scratch my patient from here. So please don't do that, but do an imaginary line. And you're imagining mid-clavicular line, fifth intercostal space. So if you already know you're at fourth intercostal space, you just feel down to or palpate to the next space. So that's fourth intercostal space, mid-clavicular line. And then after you put that one there, you put the V3, because the answer for where's the location of your third precordial lead is in between 2 and 4. Then you have your anterior axillary line. Your anterior axillary line, if you look at here, my webcam, that's the crease right here in your armpit. And you have an imaginary line here, and that's your V5. And then all the way on your side, that's your mid-axillary line, and then you just follow the contour of your fifth intercostal space. So in recap, V1, V2 is fourth intercostal space, V4, V5, V6 is fifth intercostal space, V3 is in between V2 and V4, right? So that's all your chest leads. Now, your limb leads are easy. Right arm, left arm, you put it on the fatty part of your deltoid, or even you could put it here on the anterior portion or the fatty portion of your bicep. You can put it there. And for the legs, you could put it in your thigh. And again, you try to avoid any bony parts, because in theory, the bone dissipates the electric signal. But we were messing around in lab a couple of terms ago. We purposely put it on bone. We still got a signal, but textbook will say otherwise. Now, your AVL, your augmented, here are now your limb leads. Now, I put it on my legs. Lead 1 is also known as bipolar. Bipolar meaning there's a plus and a minus, right? So it's always lead 1. You see this red arrow, and it forms a triangle here when you look at this, and that's called Einthoven's triangle. And that's why EKGs are labeled EKG, because the Germans don't have a C for the word cardio. Their cardio begins with the letter K. Go figure, Germans, right? But they're the ones who invented the EKG. So if you're looking at lead 1, you see it starts in your right arm, because remember, you're looking at the perspective of your patient, right arm to left arm. Lead 2 is right arm to left leg. Lead 3 is left arm to left leg, and it forms a triangle. And your right leg is the ground wire, okay? So right leg is the ground, and then your limb leads form this triangle between your right arm, and left leg. Now, the AVF is easy to identify because it has a little a, and A means augmented. It also means these are unipolar leads. So they go from the center of your body, and if it's AVF, it goes to your foot. And the only foot involved in Einthoven's triangle is your left foot. So AVF goes from like your heart or the middle of your body to your left foot. AVL goes from your heart to your left arm. AVR goes from your heart to your right arm. So a lovely question on the final would be, okay, where's my V3? And you'll tell me what? In between V2 and V4. Hey, where's your V6? Oh, it's your precordial lead located in your fifth intercostal space, mid-axillary line. Hey, lead 2, is that a precordial lead? Roman numeral 2, is that a precordial lead or a limb lead? And you'll remember this picture. Oh, it's a limb lead. And it starts from my right arm to my left foot. Where's my ground wire? Oh, that's my right foot. How about AVR? Oh, it's a unipolar lead going to my right arm. How about AVL? The unipolar lead going to my left arm. And the homework assignment is going to have it's going to actually be an excerpt of the exam. And it's going to have little quick questions just like this. And remember, you practice little questions in the form of these homework, right? Then what will happen? Because it sets you up for the exam. Because remember, you got to train like you fight. You already know that there's going to be a multiple choice examination, right? You also already know from the midterm, oh, he likes putting pictures. So do you think I could easily put this picture and start erasing all of this and start asking, what are you looking at? Hint, hint. Can I do this? And instead of all of this, I could just put A, B, C, D, E, F, G, right? And I'm looking at my patient. This is my patient's left side. This is my patient's right side, okay? And remember this one. This one always comes out on registry exam. Where is the location of your V3? And the answer will always be in between V2 and V4, okay? And doesn't V look like a little body? And that's how I know it's like precordial or chest leads. And this is how I remember the leads. I remember like pictures. When I was in EMS learning how to do EKG, I always did like a little dance with my hands and my foot to remember stuff. Okay? Anyone any questions on what these things are? Those are your little electrodes. Those are the things that, and then when you look at all of them together, this machine or this test is called a 12-lead ECG or 12-lead EKG. You see, there's 6 of them here. There's 6 of them here. So you should have 12 electrodes or 12 stickies that you're going to put on your patient. And when you're all done, what should you have? 12 stickies. Every time I go to the hospital, I am not exaggerating. Every time the tech leaves at least one behind, or they do these little pet peeves that I can't stand. Like they put it on my pillow, next to my head. Last time my wife was in the hospital, they put it on her pillow and it gets stuck in her hair. Come on now, basic customer service. And again, when they first started, they probably didn't do that, but it's a slippery slope. You guys know how it is. All of you guys drive, correct? You remember when you first started driving, 10 and 2, you actually stopped at stop signs. You actually look left, look right, look left again. We actually did all that. This morning, when I drove my kids to the bus stop, I totally blew all the signs. I'm driving with like my pinky. My other hand is either texting or messing with the radio. Well, we're in healthcare. We don't cut corners. We don't give into the slippery slope, and we definitely follow protocol. And brings me back to this last thing, the actual EKG procedure, which we'll be doing in lab. And the way the lab works is I show you a couple of times and then we do it on the practice dummy. We no longer do it on this dummy here because of COVID. I used to be the EKG dummy, but our EKG dummy is a small adolescent sized male and it is anatomically correct. So when you feel it, you can feel all the depressions and all the little holes and things like that. So this will be the last thing we're going to go over today. Thus far, anyone have any questions thus far? We're good? Let's wrap this up. Okay. So first thing you got to do is turn on the EKG machine. Now, back in the day, it's meant for the machine to heat up. But nowadays, modern machines have telemetry. They connect into the internet. And when you type in the patient's last name or you type in the patient number, it kicks out all the patient demographics. And what are patient demographics? Their name, age, sex, and the most important part is their diagnosis codes, okay? Because that's important for billing. And also what doctor this is going to go to and all the pertinent histories and information. Those are modern machines. And we have old machines that are like 10 years old, but they also can connect to the internet via hardwire because they're old ones. But the new ones now, maybe you guys been to your doctor's office, got an EKG machine. I went to the pediatrician's office yesterday. I saw their EKG machine. It was a iPad connected to a sensor, and then they put the electrodes on this kid, and everything lit up on the iPad, and it sent directly to the electronic medical records. It was the coolest thing I ever saw. Looked crazy expensive too. Also, when they were interviewing the patient, they turned the camera on and they were taking pictures of the patient and also getting the patient history on video. So that's awesome. During my time, how many times did a patient say, oh, it was ABC? And then I interview them again later on in the afternoon. Oh no, it was 1, 2, 3. And you're like, you messing with me? Am I crazy? So sometimes, when you're sick, your memory plays with you and you don't remember things quite well. So that having a video is really great. I thought that was really cool. Always identify your patient. Always identify yourself. Hi, good morning. My name is Nelson. I'm your medical assistant, or I'm your EKG tech for today. And do you know what an EKG is? You had one before? He goes, okay. And he goes, if you have it, it is just a test to measure the electrical conductivity of your heart. It doesn't hurt, and it measures the little impulses that come from your heart. Is that all right with you? Do you notice in that little bit that took not even 5 seconds, the patient now knows who you are. You now also obtain informed consent. And that's what's missing in this world. And the rapport is missing. The last person to do an EKG on me, she came in the room. She was like, started touching me. And I said, excuse me, you are? And for whatever reason at Inova, their IDs, they have this barcode thing or like Q code scanner. it obscures the name and their title and who they are. And that's concerning to me. I don't like that. On other hospitals, they don't have it that way. I didn't even know who the doctor was last time I was there. And that's not good. So always identify. And why do I have to identify my patient? Because how many Jeffrey Garcias there are in the world, right? Especially it goes, or John Smiths there are in the world. Or Nelson Garais says there's only me. Well, actually, me and my son. Wash your hands. Actually, wash your hands before. Now, here's the addenda protocol for COVID. You should be masked up, you should have your visor, and you should be gloved up at all times. That's the new COVID enhancement, okay? Before, all I had to do was wash my hands because it's a non-invasive procedure. I could do EKG without this, but nowadays we do enhanced PPE all the time. We ask the patient to disrobe only from the waist up. We remove any jewelry or socks. Now, bra, I just asked them to unlatch it in the back, and we could keep their modesty and keep it loose. They don't have to take it entirely off, especially in an outpatient setting. And then give them the drape or the gown, and turn your back, when, just these basic things. I once had to disrobe like completely naked, and the tech is staring at me. And I looked at him like, hey, like the show? And he was like, oh, I'm sorry. And again, commonsensical things that if you're not paying attention, and it could potentially ruin the rapport between you and your patient. You ask the patient to be in a supine position. That means lying down. I'd like modified semi-Fowlers. That's when you put the patient with their back up, because especially if your patient has a lower respiratory tract infection or any cardiac or pulmonary issues, you guys know it's very, very hard to breathe when you're lying dead flat, right? So I like semi-Fowlers position, or Fowlers or semi-Fowlers. You have to tell the patient to rest quietly. And the key is quiet. They can't speak, because if they speak, the baseline was going to go everywhere. And ask them to breathe normally. The patient sometimes is nervous, or they think it's part of, when the doctor asks them, hey, take a deep breath. I ask patient to try to breathe shallow and not move around so much, because that's important. And to not talk until I say it's okay to talk. Now, you don't have to wash the patient's skin unless they have any oils or unless they're a little bit on the greasy side. And you only use 70% isopropyl alcohol. You also do not cut any hair. Shaving is not only not recommended, you do not do it. Please do not shave. Okay, so what do? We're going to show you in lab how to clean the area and how to move the hair out of the way so it doesn't get caught up in the electrodes. But again, do not shave. Apply the electrodes to the fleshy, fatty portions of the limbs, right? And we talked about that in place. Put your precordial leads with the tabs pointed down. And what are the tabs? They're this thing. Now, this is the old school one, but these are new school ones. Why are they showing all the old school? Here you go. Here's a typical EKG electrode, and it's sticky and it's gummy, right? Look at the price, please. And this is relatively cheap, so don't waste them. You see this tab here? When you're putting the electrodes on your arms and on your chest, the tabs have to be facing down. And if the ones are on the legs, they have to be facing up. So because you're going to put the hub of all the wires on the patient's side around their waist. You attach the wires and cable, and the machine will tell you if you're missing anything. All right, and that's this part. You don't have to enter patient data because 9 times out of 10, it'll already be entered for you. But let's say, for example, you're in a mom and pop operation. I just put their full name and the physician and the date. You know, very, very basic. The full name, the physician, and the date, that should be good enough. Paper speed is at 25 millimeters per second. This is important because there's certain cardiologists, sometimes they like it slower, sometimes they like it faster. But in a typical office, it's 25 millimeters per second on a sensitivity of 1. Okay. And the standardization is usually already in there. But this 25 millimeters per second, if you look at on the screen, that you got to make sure that's the paper speed at all times, unless the physician, especially the cardiologist, tells you otherwise. Now we check for any tracings or artifacts. Now, what's an artifact? Anything that looks abnormal, like the baseline's all fuzzy, and we're going to show you those artifacts in lab. You correct the problems, and then you run it, and then you disconnect the patient from the machine, remove the tracing. Now, it's at this point the patient's going to ask you, hey, what does it mean? You guys answer me this. Do you have, it goes, what would you say if the patient asks, hey, it goes, what do you see? What can you tell me? What do you tell the patient? What do you say? When the patient asks, hey, is that normal? Is that good? What do you say to him?
I will say that the doctor will discuss it with you if I am just attacked.
Good. No, don't say just, because you're not just. You're not a nobody.
No,
You
I mean,
say,
if I was just a regular tech, I would just tell them that the doctor would discuss any results with them.
Right. Wonderful. Doctor will be with you in a moment, and the doctor will discuss to you, right? Because you know stuff. But who's the one who speaks diagnosis and management to the patient? That's your physician or the DNP, the nurse practitioner. Okay, or the DO, which is a doctorate of osteopathy, which, by the way, they act nowadays with their licensure. I don't know how to say that word, with the license, right? They're just like MDs. They do everything the same. Actually, the pulmonologist who saw me was a DO, and I couldn't tell the difference because it's the same thing. After all is done, you don't have to clean the patient, but have your towelettes ready if they want it. Have the patient help the patient back up to a sitting position, give them their privacy. Now, what should you be doing? Watch your patient for any symptoms, like for dizziness or maybe shortness of breath. And again, after you're all well and done, you deglove, wash your hands, record, and of course, make sure that all that information gets into the patient chart, either electronically or physically. Now, if it's physically, it's a mom and pop place, and you have the EKG trace. What I do is I stick it in the actual file with just the ends sticking out, so that the doctor sees that, hey, there's something for the doctor to go read. And then dispose. Make sure you have how many electrodes? How many electrodes should you have at the end of this business? 1, 5, how many?
12.
12, thank you. And of course, clean and disinfect the equipment, put the equipment in better shape than you had it before, and we'll show you exactly how that goes down in laboratory. So you could see here a lot of stuff, right? Because I remember when I was a medical assistant, I used to think I'm a low person on the totem pole. I don't know much. I only had the 6 months training thing, but you know what? You guys, I go, guess who are the nurses who have the best grades and who have the best laboratory performance? It is the former medical assistant. It's the former home health aide. It's the former CNA. It's the former low man or woman on the totem pole who's seen all of this at the lower level. And then when you see all of this at the higher level, you have a greater understanding of what's going on. And I actually took offense to it once. I had one of my medical school classmates, which, by the way, initially years ago when she found out I quit medicine to teach, she said something really, which I thought was mean to me. And she said, medical assistants, and it goes, they even have training? And she didn't even know I was a medical assistant. She was like, why are you teaching those guys? Why don't you just teach nurses? As if, nurses are the only ones who have training. And what she didn't understand, and she was a medical doctor. What she didn't understand is that we're all one big team, and the medical doctor is no better than anybody else. We just went to school a lot longer. I need that tech to be just as good as me, because if that EKG isn't done right, then does the DNP, does the DO, does the MD have enough data to do the job? No, they do not. And also, before pre-COVID, people used to kind of look down at people in sanitation in the hospital, the people who clean the room and whatnot. They're not maids. My niece worked in sanitation for a year before she got into stuff. And now she's a respiratory tech. She said, oh man, people used to look down on us. And I'm like, yep, because that's what people do. They want to look down on others to make it. But you know what? Those are the people who should have got the vaccine first. Those are the people who had greater exposure to COVID. And up till now, they're one of the last people in the hospital who got it. And it's again, I'll get off my soapbox. It's one of the more backwards things that I've ever seen. Because sanitation, what do? They make sure that room is clean. They make sure that room doesn't cause what we call a nosocomial infection or a hospital-borne infection, which, by the way, is an eventuality. If you're in the hospital more than 3 days, you're going to get a fever, you're going to get a cough, you're going to get sick, because you're in a whole big hospital full of sick people. So I'll put in like some questions to do, and that'll be your homework. And that'll be for next week. And I'll also put in the dates of the laboratory. So it's at this portion. I'm going to officially stop the recording.